Welcome back from the break. We have an awesome audience who has been very engaged throughout the morning, and I encourage you to continue to share your comments and ask questions through the question bar below the video stream. So as we're back, we're talking about early detection. And early detection is of critical importance to each individual impacted by cancer, and the broader kind of system level value of early detection is of great significance as well. Our next panel discussion on catching cancer early, reframing the system value of early detection in young adults, brings together a multidisciplinary group of experts to examine how earlier diagnosis in younger adults can impact patient outcomes, efficiency of care delivery, and long-term cost savings. This session contributes to a renewed understanding of the full system value of early detection as a foundational pillar of sustainable patient-centered care. Moderating today's discussion is a valued member of our steering committee, Dr. Tanya Chawla, who is an associate professor and staff radiologist with the Joint Department of Medical Imaging at the University of Toronto. She is joined by Laura Floyd, a stage 3 lung cancer patient and advocate, who will bring the patient perspective to this discussion. A warm welcome to Dr. Craig Earle, CEO of the Canadian Partnership Against Cancer, Eva Villalba, Executive Director of the Quebec Cancer Coalition and one of Canada's top value-based healthcare experts, Jennifer Carey, National Advocacy Manager with the Canadian Association of Medical Radiation Technologists, and Samar Saeed, RN and Oncology Clinical Services Manager at William Osler. Thank you so much for joining us today, and I will pass it over to you, Dr. Chawla.
Thank you so much. So pleasure to be here and to have this very important and timely discussion about the values of early detection and the impact it obviously has not only on individuals, but on the systemic behaviors of our healthcare system. Do we really have the infrastructure to support these needs? So we're going to launch into our discussion firstly, and you've obviously heard of all our panelists, and we're going to hear first, I believe, from Laura about her perspective and her early diagnosis.
Thank you so much for the intro and for having me here today to speak. So 5 years ago, I had just started a new chapter in my life. I was a law school grad at 39, articling at a legal aid clinic, and I started experiencing some vague but persistent symptoms. In particular, my heart rate was high and my blood pressure was high, and nothing I did seemed to help. Eventually, on the advice of my doctor, I took myself to the ER after work one day. I almost didn't go. I didn't really feel like spending all night in the ER only to be told that everything was fine, and really the problem was that I needed to get more sleep, eat better, and exercise. But I thought about my husband and our 9-year-old and decided that if there was even the smallest chance that something was wrong, I owed it to them to go get checked out. As I said, I fully expected to wait all night only to be told that everything was fine, but I was wrong about both of those things. I hardly waited at all. This was the height of the COVID pandemic, and the ER was practically deserted. Within a couple of hours, I was in with the doctors who said, "Your heart looks fine, but I want to send you for some medical imaging." They thought maybe they would find bronchitis or pneumonia, but what they actually found was a 4.5 centimeter mass growing in the top right of my lung. I don't know who was more shocked, me or the doctor who had to break the news. I learned that night, as I was frantically Googling everything I could think of, that even though lung cancer is the most commonly diagnosed cancer in Canada, with around 30,000 new cases every year, only around 600 of those are in people under the age of 50. I also learned that night that only about 1 in 5 lung cancer patients survive 5 years after their diagnosis. I was devastated, I was terrified, and I felt completely alone. I didn't know how I was going to tell my husband, or my child, or my parents, or my job about what was about to happen to me. I didn't know what was about to happen to me. And so one of the first things I did was reach out to meet other people in my shoes, people who were dealing with this diagnosis right in the middle of their lives when we were supposed to be building careers, starting families, raising our children, when the rug got pulled out from under us. And in that first year, I met 5 different incredible women. There was Elle and Ella, who were both single moms, and their beautiful children had their own unique special needs. There was Shan, who had been a powerhouse professional before her diagnosis turned her into a fundraiser extraordinaire. Ada, who had hoped to become a mother before her diagnosis and now turned all that energy to her fellow patients and to advocacy. And Sherry, whose family had finally come back together after being apart for thousands of kilometers. We shared advice, we shared stories of support, we shared all the ups and downs. We told each other things that we couldn't tell our families. And over the next few years, I lost every single one of them. The thing that I have come to learn about my story, like every survivor's story, is that it's not just about the things that happen to you. It's maybe even more so about the things that didn't happen to you. And what I've learned out of all of the things that didn't happen to me, I think the most important one is that I didn't have to try 3 or 4 or 10 or 12 times to get a diagnosis. I didn't go to the hospital and be told, you need to exercise more or lose weight or work a less stressful job, like many of my friends were. I didn't get turned away by my GP. I didn't have to wait until my symptoms were those of debilitating metastatic cancer before they were taken seriously. The very first time that I sought medical care, they found my cancer. And because of that, I'm here to share my story and a little bit of the stories of the people that we've lost. And I thank you for your time in listening to this and for being part of this very important session. As Cassandra said, it's critically important. Lives are literally at stake. Thank you so much for listening and for being part of this session.
I want to thank Laura for that very deeply personal and moving story. I think we're going to hear more about why serendipity should not form a part of the diagnosis of early cancers, more from our other speakers. It's been obviously a very painful journey for Laura, and thank you so much for being so open about the struggles that you've faced, the people that you lost on the way, and the challenges that continue to face you as you go through this moving forward. So we will circle back to Laura with some of the questions that you'll have as an audience, but I'm going to move on to Dr. Earle, who's now going to address our second objective, and he will discuss some of the systemic issues of lowering the screening age in younger patients. Thanks so much, Dr. Earle.
Thank you, Tanya. And I also want to thank you, Laura, for sharing your experience and the experience of your friends. It definitely keeps us grounded in everything that we do. So early and timely diagnosis of younger adults with cancer is obviously a good thing to do, both from a human point of view and from a system point of view. And so it's really hard to argue with things like making sure that there's public awareness of the symptoms of cancer and that physicians are aware that cancer can happen in younger people, even before there was the more recently recognized increase in cancer rates among people under 50. Patients should never have been dismissed saying you're too young to get cancer. So those things are no-brainers, I think. I'm going to have my comments mostly be about the issue of lowering the age for organized screening programs and talk about some of the reasons why this isn't always done and isn't always necessarily a self-evident thing to do. And overarching, I think it will be about the concept of opportunity cost. So modeling that my organization, CPAC, Canadian Partnership Against Cancer, has done with the OncoSim model and others have all quite consistently shown that reducing the screening age for many cancers, and if we take colorectal cancer as an example, reducing FIT to 45 or 40 result in better health outcomes. And is at least cost effective by accepted criteria. I know there are some analyses, some models, including some analyses with ours that have suggested even longer term cost savings. I should caution that the results aren't necessarily consistent on that, but at least cost effective compared to other things that we do. And even if results in long-term cost savings, it still does require upfront costs to the system. And this is where the concept of opportunity cost comes from. If you're going to spend $1 on a new program or expanding a program, what are you not spending that $1 on? What are the other options for it? What opportunity are you foregoing by expanding that program? So if we take a step back, despite the fact that it does seem clear that there are increasing rates of cancer in younger patients, still overall cancer age is an exponential risk for cancer, meaning that 90% of cancers still occur in people who are over age 50. A 50-year-old is twice as likely to develop cancer as a 40-year-old. So when you're applying any sort of screening test in a younger population, a population where there are fewer cancers to find, it is less efficient. And without going into the math, you will also find more false positives. Times when the screening test is positive, requires further tests to sort it out, creates anxiety and things like that, than at the older age where there's a higher risk. So it is less efficient to screen a 40-year-old than a 50-year-old. Now, it may still be the right thing to do. As I said, cost effective, maybe even in some situations, cost savings. But what are some of the other options that policymakers need to look at when making this sort of decision? Well, the first one is about participation in screening programs. So if we go back to the colorectal cancer example, if you look at the target high-risk screening age range of 50 to 74 in most jurisdictions, if you look across the country, screening participation rates are in the range of 40 to 60%, nowhere near 100%. And if you look within that range, it's the younger people within the range who are the least likely to get screened, 50-year-olds, much less than 60-year-olds and 70-year-olds. So it may be that spending that extra $1 to get people within the target range, getting 50-year-olds to have screening, may actually be a much more efficient thing to do and save more lives per $1 spent. The second issue is equity. So we know that screening rates for basically every type of cancer screening are lower among certain groups, low-income people, those living in rural and remote communities, recent immigrants. And if you do expand screening eligibility criteria, we know from many other similar examples who will avail themselves of that. In general, it's wealthy, educated, urban people, downtown Toronto, that type of thing. And so there actually is, and has been shown in other situations, the potential to widen disparities between the rich and the poor, the urban and the rural, when you expand a program. So maybe that extra dollar would actually be better spent on outreach programs to underscreened populations in the highest risk group. And then the last thing I'll talk about is about the downstream diagnostic resources, because it's not just about the cost of a FIT test, for example. It's about everything that has to happen either to sort out a false positive or to diagnose the cancer. So while modeling that we've done has indicated that lowering the screening age could result in 5,000 fewer deaths from colorectal cancer, it requires 500,000 colonoscopies to do that. And given that in Canada, there's something in the range of maybe 4,000 providers, surgeons, gastroenterologists, some nurses who are able to do colonoscopies, can our system really absorb that sort of thing? And is the answer the same if you're in downtown Toronto or if you're in a small Atlantic province, for example? And this one is very important because there's actually the potential to harm symptomatic patients if they can't get access to, for example, endoscopy or biopsies for symptomatic disease. It may actually delay the diagnosis of symptomatic cases and end up harming people overall. And in addition, you would create a whole new cohort of people who are likely dissatisfied with the healthcare system because, I had a positive screen and it took 6 months to get the next test to sort it out. And I think this is the reason why the resource realities are the reason why each jurisdiction really has to make their own decision on this sort of thing. This is a role that CPAC certainly plays in supporting jurisdictions. We have networks of the people responsible for organized screening programs in all the provinces and territories, and we do modeling for them. So, for example, when Alberta and Ontario reduced their ages for breast screening over the last couple of years, we did modeling to help support, okay, how many more biopsies are you going to need? How many more surgeries will you need? How many more visits? And in general, it's not actually about the money when we're working with the jurisdictions. That's very much a secondary or tertiary concern. It's about the resources. Can we actually handle expanding this sort of thing? So maybe that next dollar is better spent in hiring more radiology technicians or getting more scanners and mammography machines. And that may be something that helps both the screened population as well as the symptomatic population. So I want to applaud in particular the colorectal cancer advocacy community for taking a very measured approach to recognizing these issues and advocating for a reduction in the age from 50 to 45, and coupling it with awareness campaigns for the public and for physicians as well. There's no doubt that there are system level and economic benefits to having timely diagnosis in young patients, but I think we do have to be very clear-eyed about the opportunity costs. Colon cancer isn't the only cancer. Cancer is not the only disease. Health isn't the only need. These are the same dollars that would go to support auto workers or pay teachers. So it's very important to recognize these sorts of issues. I'm hoping that in the future, increasingly, we'll be able to use risk-based approaches to being able to recognize who we should be focusing our screening efforts on, because there are 40-year-olds who have higher risk than 50-year-olds. And if we can identify them and prioritize them for screening, it can increase the efficiency and overall save as many lives as we possibly can. Thank you.
I want to thank Dr. Earl for a fantastic and very balanced presentation of some of the real world issues that come with this two-pronged approach of dropping screening ages and the impact that it has, not just in terms of false positives and anxiety, but of the downstream costs. We obviously have the one pot that we have to share in a very limited and measured way, and certainly risk calculation plays a big role. Obviously, colorectal cancer is one cancer, but we have a legion of malignancies out there that need to be individually thought of as we divide that pot up. So you're now going to hear, I think, a little bit of the other side of the coin. So we're going to address our second objective. And for that, it's my pleasure to welcome Samar Saeed, who's going to talk to us about how early detection improves resource utilization and the impact that it has on survivorship outcome. Thank you so much.
Thank you, Tanya. And I would like to thank Laura for sharing her story. Laura, it is your voice and other survivor and patients who keep the rest of us coming to work every day and trying to improve the system for everyone. So I really do appreciate you coming out today and sharing your story. And thanks, Dr. Earl, for giving very balanced and very realistic picture of the challenges that faces our system. I'm going to talk about two examples for the positive example for early detection and how it can help us from both system level and also in terms of survival rates and patient experience and improved patient outcomes and improved patient experience. So lung cancer. There's been a lot of research about lung cancer and the use of low-dose CT screening to help early diagnoses. And the use of low-dose CT screening actually shows in some researches that shifts diagnosis from 70% late stage to 60% 60% early stage. In early stage lung cancer, when they're treated and then when they're captured, then they will be treated with lobectomy and SBRT instead of intense chemotherapy and intense systemic therapy in general. Now, if you look at, untreated late-stage lung cancer, it does create high pressure on emergency rooms. It leads to increased ED utilization due to, dyspnea crises, malignant pleural effusions, infections, pain crises and sort of things, where early stage diagnosis reduces hospital admission 30%, and in some countries like the UK, it shows a 50% reduction in hospital admission. It also leads to early stage detection leads to survival rate being, between 68 to 90% in some of cases, compared to, late stage detection, which survival rates then is less than 10%. The UK had piloted a randomized trial where they used low-dose CT screening among high-risk individuals to help them detect lung cancer. And out of those who were screened, 2.1% had confirmed lung cancer. And out of those cases, out of those confirmed cancer, 66.7% were stage 1, where about 19% were stage 2 lung cancer. So surgical resection was possible in 83.3% of the diagnosed cases. And when they did from a quality adjusted life year perspective, the cost saving was about 8,000 pounds, like actually a little bit more than 8,000. It was 8,466 pounds per year. Although now, when you take into consideration, screening does cost money, and there are costs associated with screening and follow-up, as Dr. Earl mentioned earlier. Though in UK, they actually found there was substantial cost saving when we look at, the opposite coin, when, those cancers who were caught in a later stage needed a lot more treatment, a lot more aggressive treatment, a lot more hospitalization and admissions, and due to respiratory failure, malignant diffusions, and so forth. So in the UK study, they did find that early detection reduced the burden on the system. It also reduced the burden on oncology beds, ICU, and palliative services. It also had early detection had much higher survival rates. It gave about an average of 3.3 years of life for each of these cases. And also improved quality of life for those patients. It meant less aggressive therapy, fewer complications, and potentially curative treatment versus the maintenance treatment. The other case I want to look at is the Ontario breast screening program, and so this program is done through Cancer Care Ontario, and they took a large cohort of women, about 48,000 of women, and they were diagnosed between the years of 2010 and 2017, and they found that significantly higher breast cancer mortality in women who did not go through the screening that the Ontario breast screening program had. And the study even also showed that even those women who didn't fully comply to the screening guidelines, and they did partial screening, they had a lot lower mortality rates than those women who did not go through any screening. And also the stages at diagnoses, women who screened via the Ontario breast screening program tend to had earlier stages of cancer compared to those women who never screened. And also, according to the annual report of the Ontario breast screening program, about 62% of these women had invasive breast cancer types that they were detected through the screening program, but it was in early stages of the cancer, which meant more breast conserving surgeries, lumpectomies, rather than having the full mastectomy, plus also less aggressive adjuvant therapy. This also reduced the demand on chemotherapy suites, again, and patient oncology beds, palliative care, because many screen detected cancers can be treated curatively with lower resource intensity. The screening program can also show that it can be cost effective if early treatment, as early treatment costs are typically lower than advanced cancer and advanced stages. Survival rates in stage 1 cancer, when detected via screening, is very high, especially the 5-year survival rate. In some studies, it shows close to 99 to even some 100% survival rates compared to later stages of cancer detection. Thank you so much.
Samar, thank you so much for sharing those real world experiences of several cancer types. We're certainly aware that those cancers that are picked up through screening have much better outcomes, present at less advanced stages, and really have a better survivorship profile as well. So we will circle back to you, obviously, to discuss some of this in the light of subsequent discussions. But it's my pleasure now to introduce Eva Villabala, who's going to talk to us about value-based healthcare and the broader systemic strategies as to how they impact investment in early detection. So thank you, Eva.
Thank you so much. And thank you for having me. Thank you, Laura, for sharing your story. I wish, as a patient advocate, that just hearing these stories would be enough to get the government to reallocate their priorities, but it is not, unfortunately. And so what we've been doing in Quebec and across Canada is trying to raise awareness about this value-based healthcare approach, because it ties in what matters to patients, which is not just survival, but also quality of life and the outcomes that matter to them. And it ties that to the resources necessary to actually create healthier societies, healthier systems. And so what do we measure in our health systems today? We measure volume, we measure services. Everybody gets a service, everybody gets a colonoscopy, but everybody doesn't want a colonoscopy. Everybody doesn't need a colonoscopy necessarily. How do we actually decide how we prioritize which resources and for who? And so value-based healthcare helps to make these decisions about healthcare service design, about care delivery, about resource allocation, and importantly, it defines value as value for patients. And then if it's value for patients, it's value for everyone else in the healthcare system, but not vice versa. If it's value for the healthcare system, often it's like cutting costs. If it's value for doctors, it's like, let's make, the scheduling of appointments according to what works for medical professionals, which, makes sense. But if the goal is to make patients healthier, we're going to make better decisions. So I'm going to tell you a little bit more about how that actually ties into screening and early detection, because the most important part, and you might have seen this formula, but it really confuses people, which is value is equal to improvement of health outcomes for patients. That's the denominator, and the denominator is costs, but over the whole trajectory of care, over the whole care pathway. And the issue is that we tend to have this very hospital-centric point of view about the health system. But actually, if you define the care pathway starting from screening and early detection and diagnosis, that's very different than if you started at the hospital once you get your diagnosis. Because as we know, with young people, affected by cancer, that period between the diagnosis and how long they have symptoms for, or how long they have the cancer, it could be very, very long. And meanwhile, the cancer is advancing, right? And so if we really prioritize an investment in prevention and early detection, that means we think about what resources do we need to use, and what are we getting for our money? Is the population going to be healthier? So often when I can talk for hours and hours, but I have been tasked with talking very quickly about this, and it's a challenge. So I'm not going to go into how we measure patient-reported outcomes or patient-reported experience. Obviously, we look at clinical reported experience outcomes as well, process metrics like delays. But I think, we've been talking a little bit about the investment, and I just want to bring it down like more concretely, okay? There's 4 potential screening programs in Canada. Okay, everybody knows about breast. And in Quebec, actually, to bring a Quebec perspective to the conversation, we participated at the Quebec Cancer Coalition. Ines was looking at reducing the screening age to 40, like in some other provinces. And they looked at it, they talked to us and other groups and patients, and they said, oh, you know what? We really want to reduce it. We want to lower the age to 40. But our system just can't handle it. So a couple of, the speakers talked about capacity issues and how do we actually get capacity? How do we squeeze more out of the lemon that's already dry? We already have issues with like not enough, health technologists and not enough doctors. In Quebec, we have issues with having access to family doctors. So how do you squeeze the lemon more? Well, you can't improve the existing system that doesn't work. You have to redesign the process with value in mind, with improving access for patients. And we have a couple of ideas about that. But so the breast cancer screening age, finally, we decided to do it at 45. And like Dr. Earl was saying, let's try to improve the existing project for 50 and over. And also now they said 45 is fine, but if we lower it to 40, we're going to be neglecting, we're going to be increasing the inequities with the underserved populations that are at high risk. We have another issue, another promising perspective in Quebec with Dr. Jacques Simard, that's developing a saliva screening test for breast cancer to actually have a polygenic risk score, basically to detect even amongst younger people, those that are at higher risk of detecting breast cancer, and to give them this kind of accelerated pathway to screening. So that's interesting for breast cancer. But we talk a lot about breast cancer, so let's talk about the other stuff too, the other cancers. So we know that with cervical cancer is 90% avoidable. Why are people still getting it? Why are people still dying from this? This is unacceptable. And many countries in the world have an objective to reduce cervical cancer altogether. As an advanced, Western country, we should really be making this a priority. I know CPAC has worked on it, and Canadian Cancer Society. We work a lot with HPV Global Action. But it only costs like $360 to do the pre-diagnosis, to actually catch cervical cancer before it becomes cervical cancer, to catch precancerous lesions. And so that's a huge saving compared to the $250,000 that it costs to give immunotherapy in a stage 4 cervical cancer. So nobody should be dying from this. We really need to prioritize investing that $360. And now with the, we're switching from Pap testing to HPV testing, which is more cost effective. You do it less often. It's much more precise. That's really where we should be going. So that's a low hanging fruit. That's like the first cancer that we should be focusing on eliminating. And while we're at it, with vaccination, we can eliminate all the other cancers related to HPV, including head and neck cancer, which is even more prevalent, and yet we don't talk about it. So investing in that would be great. Next related cancer is with colorectal cancer. We can also catch precancerous lesions. And so with education, all the great work that CCRAN is doing, but even if you catch it in early stages, it costs $25,000 on average for a stage 1 compared to $90,000 for a stage 4. So we really need to educate people, yes, with all the lifestyle changes and all of that, but not only. We really need to try to make sure to show that people are doing better, and that it actually, there is this upfront investment that Dr. Earl was talking about, but that in the long run, basically having a value-based healthcare point of view makes us think more in the long term than in the short kind of electoral cycle or annual budgetary cycle of the hospital. The short-term view makes us lose sight that even though we're investing a little bit more upfront, we're actually saving lives, number one. And number two, we're actually saving the very limited resources that we have. So, and then lung cancer. Lung cancer is one of the last. Cervical and lung are kind of competing for like which one is going to be the next to be formally launched. Thanks to a grant, I believe, from CPAC, actually, Quebec had this really great pilot project. Thank you so much, because I don't think they would have done it if we didn't have that. And now they're like, we really want to, but we're lacking capacity. So again, this capacity issue comes up. And there has to be a time when we kind of say, we're going to be investing more in prevention and early detection, and then eventually, within a couple of years, but not immediately, we're going to start seeing savings in what it costs us for advanced stage cancers. But it's a societal choice. We need to make that choice, and it's not a politically sexy choice. And so that's kind of what's been limiting us. But in Quebec, we just recently launched our national prevention strategy, in which we pushed very strongly to prioritize this. So we're actually hoping, and we're crossing our fingers, in March we'll find out, but we and many other organizations that are part of this coalition for a reduction of disease are asking for doubling from like 2% to 4% the investments in prevention and early detection. So That's for lung cancer. We actually don't even have good stats on like how much it costs us for early stage disease, because almost everyone is caught in a stage 3 or 4. But we know that even the difference between a stage 3 and a stage 4, the prognosis is so much better, the quality of life is so much better. But also it costs like less than half just from stage 3 to stage 4 in a lung cancer. And so think of all the resources necessary, think of the impact on the community. It's really a no-brainer, but it's, like I said, politically a little bit difficult. Now, if we look at if we have that longer term view, there's potentially billions in savings from the lives saved, but also from treating people in early stage. Often when you treat people in a stage 1 or 2, you can just do surgery, a little bit of radiotherapy, but you don't have to go to all of the expensive, immunotherapies and cell and gene therapies and all of the precision medicines that are amazing, but we should just try to minimize how many people we catch at that advanced stage. So the goal would be a healthier population, more return on investment of our taxpayer dollars, instead of spending so much money on these like very expensive, like last ditch efforts to save people that are in advanced stage. Let's try to catch people early. And then obviously the societal impact. So I did want to add something that was mentioned before. We've actually done a really interesting value-based healthcare demonstration project in colorectal cancer, thanks in part to CRAN as well, where we actually, talked to patients, survivors, caregivers, understood what mattered to them, and then we measured it regularly. We integrated care at the Jewish General Hospital in Montreal, and now we published it, and we're trying to get the whole cancer system in Quebec is going to be applying it. Now, we had originally started with diagnosis because it was easier, and now they're moving it back to optimize that phase between the pre-diagnosis phase and the diagnosis phase. And we're replicating this. For your information, Laura, you'll be happy to know that we're doing it in lung cancer as well, in a Quebec City hospital. And the goal is really to demonstrate the value of accelerating that early diagnosis, accelerating that time from suspicion to diagnosis to treatment, and so that people do well, so that the goals of care are that people are healthier and not just that we, find the cancer and treat it and that's it, but really the whole health of the person, and how every single professional, whether it be nurses, doctors, imaging professionals, and the patient as a partner of improving how we actually conceive, how we can start to have a more design and systems thinking approach to improving the trajectory. So we don't just have to keep fixing what's kind of broken right now, or in the words of one of my mentors, like reinventing the wheel, but it's a flat tire. Like, let's have flying planes instead of cars with flat tires. Let's reimagine how we transport. Let's reimagine how we have our healthcare system, and the way that we do that is by really working not just for but with patients, and measuring value from the perspective of patients. So thanks for that. I'm happy to answer questions later.
Thank you again for that very comprehensive discussion on value-based healthcare. I think you brought up some very important points with regards to risk modification and education, and certainly I hope we can circle back to that in terms of how some of the disadvantaged populations may have less access to those sorts of resources as well, with a view to minimizing risks for certain cancers, which obviously are more susceptible to those factors in particular. So yeah, Eva, thank you again. And we're going to now move on to our next and final objective with our last speaker, Jennifer Carey, who will be speaking on a topic close to my heart. And she's going to be talking about some of the imaging advances, how they can impact resource utilization in early imaging diagnosis. What can we do to try and reduce overall imaging burden? And this is obviously moving away from people who are in the screening subset, but perhaps have established diagnoses or are being staged, for instance, as well. And how can we strengthen that case for investment in the setting of early age onset cancers? So Jennifer, thanks very much for sharing your knowledge and your perspectives as a MRT. Thank you.
Thank you so much. And I'm really honored to be here to bring the medical radiation technologist perspective. Unfortunately, it is not one that is often considered in discussions like these, but my profession is intricately involved in diagnosis and treatment of cancer. So I know we have a lot of patients and care providers in the audience. So you may be asking yourselves, what is an MRT? I've never heard that acronym before. That's not terribly shocking. But you may not know the name of my profession, but you definitely are familiar with the work that we do. If you have ever had a CT scan, an X-ray, an MRI, a PET scan, a bone scan, if you've ever received radiation therapy, you would have received care from my profession. And we are at really at the point of care in diagnostics and treatment, particularly as it pertains to cancer. And so from my profession's perspective, when we're looking at this question of early diagnosis, cancer rates increasing in younger and younger adults, what is the linchpin from our perspective? And really, when I think about it, I think about how is cancer diagnosed? And it is typically diagnosed as it pertains to the cancers that my profession diagnoses in one of two ways. Established screening programs, which we have talked about, or kind of happenstance, as Laura, identified in her story, vague symptoms, not necessarily indicative of a giant red flag leading to, yes, this is cancer, but kind of a general symptomatic process that could be something, could not be something, we're not sure. And so when it comes to screening programs, my profession performs the exams for 2 out of the 3 that Eva identified. So my profession does breast cancer screening. So the mammographers that you meet when you go for your breast screening, or if you need follow-up diagnostic examinations, that's my profession. And as it's being rolled out in different pockets across the country, low-dose CT scanning for lung cancer diagnosis, that is my profession. The technologists performing those CT scans are the ones that are doing the testing that is diagnosing those cancers. And so when we're thinking about those things and how those, those screening programs are growing, we've seen it in breast cancer where the age has been lowered in a lot of provinces. We're seeing the broadening of the implementation of low-dose CT scanning for lung cancers. We've seen different, and this is what I love about panels like this. We see an issue from very different facets and perspectives, which allows us to have a fulsome conversation of how this affects the system as a whole. From my perspective, when I hear about these things as a profession, we understand, we see every day, whether we're on the diagnostic side or the therapeutic side, we understand that the sooner a cancer is diagnosed, chances are the better the outcome, the more treatment options that are available to that patient. So we as a profession are proponents of whatever we need to do to get these cancers diagnosed earlier. We know that equates better outcomes for our patients. But, understanding that my profession plays a huge role in diagnostics, it is unfortunate that at the same time, my profession is experiencing a huge health human resource crisis right now. So what does that mean? That means that there are, the demand for the services that my profession provides, the demand for CTs, the demand for X-ray, the demand for MRI, the demand for radiation therapy is going up and up and up. But the number of medical radiation technologists in the country has stayed relatively stagnant. Which means, as the patients and care providers in the room, when you look at your provincial statistics of how long wait times are, they have skyrocketed. And, for screening programs, that is not felt as an acute level because those kind of appointments are integrated into the existing system. Who that primarily affects are the LAURAs, who have kind of a vague symptomology, not directly indicative of a disease process. So you go to your family physician usually, and I wanted to say thank you, Laura, for sharing your story, and I am thankful on your behalf that you were listened to the first time around because most of my patients are not. And because they present with a vague kind of symptomology, you go to your family physician, you say, I don't feel right. This feels weird. I'm experiencing this. I'm not really sure about this. And, if you are lucky enough to kind of be able to navigate that system, you are then put on a list. But because your symptomology is somewhat vague, chances are you're going to be put on a lower priority, which is what all of these exams are categorized as. It's a triage system. People who have kind of more expedient or more emergent symptoms get seen first. And people with the kind of vaguer symptom processes have to wait a bit longer. And so because there are not enough medical radiation technologists in the country currently, we're seeing skyrocketing wait times for those patients, primarily in CT and MRI. And so what we're seeing as practitioners, both on the diagnostic and the therapeutic side, is we're seeing later stage diagnosis. So by the time they get to us with that vaguer symptomology, we're seeing things that, you know, if this had been scanned 6 months earlier or 8 months earlier, a whole different treatment outcome would be possible. And so we feel that acutely, and we understand that. And so, you know, from a how are we going to change this? I mean, I don't want to say how are we going to fix it, because I don't think it's not either or. To me, it's yes and. You know, we need a value-based approach to healthcare, yes, and we need an economic model to figure out what the best way is to carry out screening and diagnosis, yes. And we need kind of, you know, established research to figure out what the best pathway forward is. And yes, and we also need more healthcare professionals, more medical radiation technologists to be able to carry out these essential examinations and treatments. And so knowing that, and knowing that I am in an audience of fellow practitioners, but also patients and care providers, you know, I can, as a professional, advocate to my provincial government or to my federal government. I can advocate and say, hey, you need more of us. And they're going to come back and say, yes, we probably do. But of course, you're going to say that because you want more of you, which, yes, true. But they tend to listen more to patient voices than they do anyone else. And so I would encourage patients who are listening today that if you have had to wait, if you know that there are certain benchmarks in the country of what timeframes people should be seen in, and that did not fit your circumstance, that you would raise your voice and advocate for greater access and more healthcare professionals in order to be able to have that access. Now, it's not all doom and gloom, you know, understanding that there's a health human resource component to it. But as Dr. Chawla said, there's also a technological component to it. And thankfully, there has been a lot of technological advances within the diagnostic imaging and radiation therapy sphere that allow us to take examinations that used to last 30 minutes, 45 minutes, and be able to shrink that down to 10 minutes, 15 minutes. Sometimes shorter in the case of CT. So that is extremely encouraging. And we are, you know, always kind of excited about those advancements that allow for certain aspects of a patient's appointment to be shortened to allow us to have more people to be seen. At the same time, we recognize that, you know, I often say to my colleagues, patients are not pieces of meat on a table. That's not the care you want. That's not the care I want to provide. And so, yes, scanning time sometimes, or the amount it takes me to do the test may be shorter, but I still want you to be able to have enough time for me to explain to you what is going on, for me to explain to you and answer any questions you have. So yes, while there is technological advances that are allowing us to fit more patients into the run of a day, we never want to think that a shorter scan time, you know, is the solve of the problem, because you don't just need a scan, you need care, and we want to provide that care. So all of that to say, you know, that when it comes to decision making, I think it's really important that governments and hospital administrators and you know, policymakers understand who are the professions that are carrying out these diagnostics and therapeutics. Who is it that is part of this care team, and making sure that all perspectives are understood and given when it comes to holistic ways to solve issues around early diagnosis and effective treatment.
Jennifer, that was great. I think it's really important for people to recognize the huge human resource issue that we're facing, not just in medical imaging, but in the medical profession as a whole, and the impact that it has in terms of delivery of services to our patients, to their caregivers, to everybody who kind of in every walk of life is needing imaging as part of their journey in health. So we have a couple of minutes, and I just want to be respectful of time. I'm going to ask Laura perhaps to join us again to give us a sense of what she feels she's learned from this discussion and what she'd like to reflect on as part of her journey getting to this point. Laura, would you like to just come and share your thoughts with us before we have a couple of questions?
Yes, thank you. Gosh, I have so many notes here. I'm going to be processing all of this for the next little while. It is so helpful and really a privilege to get to hear all these different perspectives at once, because I think just as Jennifer had just summed up with, government policymakers, admins, it's important for them to understand all that, to understand all of the complications and the layers and the factors that get involved, not just for my care, but for every individual's care. So many things have jumped out at me, and I'm really appreciative of everyone who works in this space and who have chosen this particular field to work in. Like, on behalf of patients, thank you, because it's clear that you're all so very passionate and committed to it, and you are making a difference. So that's what I would just like to say to the panelists, to thank you for all of your work as well.
Thank you so much, Laura. Okay, so I'm going to take, in the last couple of minutes, just take a couple of questions. And the first one I'm going to bring up to the panel is, what is being done to assess the societal benefit of early detection in young adults? And obviously reminding you as a panel that when we catch these cancers early, we impact the ability of not just the patient, but their caregivers to contribute to society, not only just from their value, but also from a sort of financial perspective. So I'm not sure who'd like to take this question.
I'll jump in maybe and say, from a practical point of view, these are the types of things that we look at when we try to support jurisdictions in making their decisions around these issues, and convening experts to give insight, et cetera. So definitely an active area in supporting decision making.
Anybody else like to chip in on societal benefits and what's being done to address those at all?
Well,
If not,
I can add something quickly, which is this morning it was the Quebec Cancer Program's kind of annual congress, and one of the things that they were talking about is how it's unsustainable how much money we're spending on oncology drugs. It's literally 65% of hospital budgets for all drugs. 65% is for oncology. And the reason is because we have all these amazing drugs that are having a huge, amazing impact on overall survival. Fantastic. But it's mostly for advanced stage disease. And so if we're saying on the one hand, this is unsustainable, and on the other hand, we're not investing in what would actually make us spend less money on medication, which is early detection, then, I think it's just coherent. If we take that same, realization that it's unsustainable, and then we take that money and we make the decision for in the short term to invest more in early detection and screening, but at the same time, for the first, 1 to 3 years, we're still going to have to pay for those expensive drugs. So it has to be a kind of political decision to prioritize investing in prevention and early detection.
thank you very much. I think we are actually almost out of time. I do have a long question for Dr. Earle, if that's okay with you, very quickly. There was a little bit of a discrepancy with the modeling that was completed through CPAC and some of the modeling that was actually shared earlier today by Dr. Brenner and his team that showed not only the life years gained in colorectal cancers in the 45 to 49-year-old cohort, but there's a net cost saving of over 2 million in the long run by introducing FIT-based screening followed by colonoscopy. So that modeling illustrated that 15K cases would be caught and 6,000 fewer deaths would result. And obviously that's discrepant with some of the CPAC data that's come out. Would you like to comment on that?
So that is a long question that would take a long answer. The modeling that was presented earlier, I believe, is CPAC modeling, and there is actually a cost effective, but it is unclear that there is actually overall a savings. But in any, regardless of how you look at the modeling, It is cost effective, and cost isn't the primary issue here. It's, I would argue, that resources in our system, as well as things like equity and making sure that we're targeting the highest risk people, are actually the more important issues.
Okay, so with that, we're going to finish off, and I'd like to thank each one of the speakers for sharing their individual perspectives, in particular to Laura for being so open about her journey, and to each one of you for bringing important propositions to systemic issues that clearly need addressing, but probably require more of an individualized approach in our very complex patient populations. Thank you so much for joining us. We hope you enjoyed the session.
Thank you, Dr. Chawla. That was a very balanced discussion. And I think it was Jennifer that said, it's so nice to bring these multidisciplinary panels together with diverse perspectives and have some really great discussion. So thank you to Dr. Chawla, who is actually the newest member of CRAN's Medical Advisory Board. Thank you to all of our expert panelists, and especially thank you to Laura for very vulnerably sharing your lived experience with us through that discussion. We'll take a very brief pause, a kind reminder that you may need to refresh your browser in between sessions, and we'll see you there. Thank you.